Hello, and welcome to the 22nd International Congress on Wavefront Sensing. My name is Jason Marsak, and I'm one of the organizers of this year's Congress. As we begin today, I would also like to recognize my fellow conference organizers, Dr. Gunyong Yoon and Dr. Ronald Kruger, as well as Christina Rodriguez, who serves as the Congress Principal Director, and Christine Morrill, who serves as the Congress Technical Director. I'd also like to thank our generous sponsors for their support of the Congress, Alcon Vision, Cooper Vision, and Johnson & Johnson Vision. The first Wavefront Congress was held in Santa Fe, New Mexico in 2000 and had 100 attendees. From that beginning, the Congress has met yearly in person. This year's meeting is clearly different. And instead of being able to have a single in-person meeting, this Congress is organized as a series of 4 two-hour webinars, with each webinar broken down into 2 distinct emphasis areas. Each emphasis area is further broken down into 15 minutes talks by world experts in topical areas. Today is the first webinar in the series, and we'll cover topics related to emerging spectacle contact lens technology and advanced IOLs and presbyopia correction. Additional webinars will follow on May 26th, June 16th, and June 30th. If you enjoyed today's webinar, we encourage you to tell your colleagues about upcoming webinars. Thanks to the generosity of our sponsors, we are able to offer complimentary registration for all attendees. It is our hope that we can use this opportunity to make this content available to as many of our colleagues and future vision scientists and clinicians as possible. For the full program details, please visit wavefrontcongress.org. With that, I would like to open our first session today, entitled Emerging Spectacle and Contact Lens Technology. There are 4 talks in this session, and each talk is scheduled for 15 minutes. You can put questions, should you have them, in the Q&A box associated with the webinar tool here, or you can raise your hand digitally and ask your question during the question period. Time permitting, we will also have a 10-minute panel discussion at the end of the session. Our first speaker today is Dr. Carly Lam on the topic of new myopia control spectacles, DIMS. Dr. Lam.
Thank you. So good day, thank you. I am pleased to be here today. I should have given this talk a year ago, but due to the pandemic, I'm very cherished this opportunity to come back to this conference. And today I'm going to explain and share some of the latest findings of the DIMS myopia control lens. I think you all know that myopia control is a big topic now for eye care professionals. So prevalence of myopia has been described to have increased in the last few decades. And in this world map of prevalence among the adolescents, myopia in Asia has hit the highest to be around 80%. And while the prevalence in Europe, America, and Africa was found to be less than 50% in general. But there has also been studies reported an increase in this European and American population. So for example, in the United Kingdom, data from the NICE study in 2016 reported myopia prevalence was more than doubled over the last 50 years among the young adults. And clearance and children are becoming myopic at a younger age. We also know that the reason why myopia should be better controlled because there are impacts in visual, psychological, financial, and economical aspects. Most of all, pathological myopia leading to visual impairment in later life and could end up with low vision and poor quality of life. I always remember Peggy in the book, The Lord of the Flies by William Golding. So among those kids fighting for survival, there was Peggy. He was very myopic. Sir Golding described that his thick spectacle lenses and frame had made a deep pink V on Peggy's nose bridge. He needed his glasses to see to be useful among the other boys, but when his glasses were smashed, he became useless. He became so vulnerable and eventually did not survive and lost his life. So this story always reminds me that myopia brings unnecessary weakness to a person, and that if we can stop myopia, we should. And animal models have confirmed that refractive development is linked to the visual guided feedback process in the developing eye and integration of simultaneous multiple defocus during eye growth determine the ultimate refractive status. So most of these studies reported myopic defocus, and that is an image formed in front of the retina can retard eye growth and retard myopia progression. So we translate the animal findings into useful myopia control methods. The first step of our lens design was a contact lens, and we call this the defocus incorporated soft contact lens, or simply the DIS lens. So this is a contact lens with concentric rings, and that the center zone is for correcting refractive error. Then there is the first myopic defocus range of plus 2.5 diopter. Then the rings alternate between the correction power and the myopic defocus power. So this pattern provides clear vision for the wearer and at the same time induce myopic defocus to retard eye growth. So in the 2-year RCT, the overall retardation effect of the DIS lens was around 25%. And these two figures show the changes in myopia progression and axial length over the 2 years. So we did not see any plateau effect during the 2 years. And we also noted that there was a dosage effect with the time of myopic defocus exposure. And in this figure, we plotted the contact lens wearing time versus the change in the ocular refraction. So for children having worn the DIS lens for more than 8 hours, the retardation effect reached 60% with a mean difference of half a diopter. So this is our very first initial trial. And then, of course, there are limitations for children to wear contact lenses. So we try to develop a spectacle lens with the same principle. In the design of a myopia control spectacle lens, instead of the concentric ring, we now use multiple lenslets. So in this figure on the right shows the design of the spectacle lens, and we call this the DIMS lens or the DIMS technology. So at the mid-periphery, there are around 400 lenslets of 1 millimeter in diameter and power of plus 3.5 diopter. And they surround the central zone, which is for distance correction. So the total area between the two power zones is about 50-50 ratio. So these children are wearing the lenses, and those multiple segments are so fine that they are hardly noticeable, unless that we shine a light onto the lens, and that will cast a shadow and show the honeycomb pattern. So the multiple segments cast blur images onto the retina. So the degree of blur depends on the distance of the target and also the position of the target being seen. So when the light ray goes through the center where there is no myopic defocus lenslets, the image is very clear as indicated by the letter E shown in A. At the other eccentric positions, where light rays go through both the distance correction and the lenslets, the blur image overlaps the clear image, and it is dependent on the distance of the target. So you can see the blur level from box B to D that is related to the distance of viewing when accommodation is not active. So there is a slight compromise of visual acuity when using this method for myopia control, but in our 2 years RCT, all the children get used to the lens very well. And we have come across questions on whether the DIMS lens is the same as the progressive addition or bifocal lenses, that they both use hyperopic addition as a mean for myopia control. So in fact, the mechanism is quite different. So PALs works on ocular accommodation system with the purpose to enhance accommodative response and also reduce the lack of accommodation. So the hypothesis behind is to ensure seeing accurately and clearly and reduction in accommodative lag so that myopia progression can be retarded. But in contrast, the myopic defocus in the dim lens is not for seeing at all, but just at the background, stimulating a constant blur. So we tested the accommodative function at the start of the lens wear and also after 2 years of the RCT, and there is no effect on the amplitude of accommodation and the lack of accommodation when comparing those children wearing the DIMS and those wearing the single vision group. So likewise, undercorrection aims to work on the accommodative system. So myopia control effect in the pairs and also undercorrection was found to be minimal. So having the lens design, we also conducted a clinical trial to evaluate the efficacy of myopia control. The trial was also 2 years and replicate the same clinical protocol as the DIS lens. So children were masked to assign to wear DIMS lens or single vision lens. So psychoplegic refraction and axial length were measured. The primary outcome would be the changes in these 2 parameters. So subjects recruited for the trial are Hong Kong ethnic Chinese children aged between 8 to 13 with aspherical equivalent refraction between -1 to -5, and they have no prior use of any myopia control methods. So here are the 2 years results at every 6 months, changes in the myopic progression as well as changes in the axial elongation. So the DIMS group is presented by the green line and the control group is presented by the orange line. It is obvious that DIMS group had a slower myopia progression and also less increase in axial length over the 2 years. So the overall efficacy of the DIMS lens was 59% in terms of myopia control and 60% in terms of reduction in axial length. These results are comparable to recent trials in ortho-K and contact lens, but among the best among treatment effects in spectacle lens. So we conclude from these 2 years RCT that wearing the DIMS lens can significantly control myopia by about 60%, and the visual functions were not different between the single vision and the control, the single vision control and the DIMS lens group. And DIMS lens wear had no adverse effect on the measured visual functions. So at the end of the trial, we offer our participants to continue the follow-up and lens wear. And this time, all children were assigned to wear the DIMS lens. So the group of children from the control group started to wear DIMS lens, and this group is retitled as control to DIMS group. And the same measurement and protocol was adopted, and this includes the axial length measurement as well as the myopia measurement. So children were now 2 years older, and the criteria for ocular refraction was not applied in the follow-up study. So these 2 tables show the comparison of the subject number between the 2-year RCT and the 3rd-year follow-up. 75% of the subjects remain in the follow-up study. The table on the right showed the 3rd-year enrollment and dropout numbers. So at the end of the 3rd year, 65 subjects from the DIMS group completed the study, and 55 subjects from the original control completed the 1-year follow-up. So the clinical results of this 3 years follow-up is mainly divided into 2 parts. We will present both the original DIMS group and the control to DIMS group. Children wearing the DIMS lens continue to show good myopia control effect. The annual changes in myopia progression were on average -0.18 diopter. And this progression rate was quite linear over the 3 years, and these results could imply that myopia control effect was sustained at around 50 to 60%. And for the children who were original control group, the myopia control effects was quite significant. From this figure, in the first 2 years, while wearing the single vision lenses, the progression rate was like 0.49 and 0.38 diopter in the first and the second year. But after switching to the DIMS lens, myopia progression was down to only minus 0.05 diopter for the third year. This figure shows the axial length changes in the DIMS group, and again, very steady and consistent increase in the annual axial length of around 0.1 millimeter per year. And in the control to DIMS group, the third year changes was 0.12 millimeter as compared to the 2 years changes of 0.29 and 0.2 millimeter. So children once switched to wear DIMS lens benefited with myopia control significantly. And at the end of the third year, 21% of children in DIMS group did not have any myopia progression. And these findings were similar to the 2-year trial for the DIMS group, but single vision group only had 7% of no myopia progression. So in terms of axial length, 40% of children in the DIMS group did not have any increase in axial length, and again, similar to 2-year RCT, and as compared to the none in the single vision group in the RCT. So in conclusion, for children wearing the DIMS lens for 3 years, myopia control effect sustained. Both myopia progression and axial length changes were similar to the previous 2 years RCT, and therefore the estimated efficacy to be around 60%. And for children who switch to DIMS lens, myopia control effect is present and in similar trend to the age-matched DIMS lens wearers. So DIMS lens offers a non-invasive, convenient treatment for myopia management. I would like to declare that the information in this talk is based on a collaborative research sponsored by Hoya Corporation, and the lens is co-developed and patented with Hoya Corporation for myopia control in young children. I also like to acknowledge the project team for the DIMS project, and thank you.
You talked a little bit about like the blur looking when the subjects are looking off axis, but could you tell us a little bit about what they were telling you about their visual quality when they were looking through the periphery of the lens? What were they reporting to you?
Yes, there is a slight reduction in visual acuity at both high contrast and low contrast and under photopic and mesopic condition. But the overall changes is like a couple of letters. And so it is hardly noticeable. Mm-hmm. So there are three papers supporting the visual performance of the DIMS lens is acceptable. So I can share those 3 papers.
And it looks like Jim Schweigling has a question.
So just a couple questions. So I would expect compliance with spectacles to be better than contact lenses in this group. Is that traditionally true?
Yes. So the dropout rate is much less, and children tend to wear the spectacle lens like for the whole day from 12 to 15 hours. But with contact lenses, the dropout rate was very high, about 50 to 60% stay on. So about 40% drop out. And the wearing time also is an issue. So some only wear the lens for a short period of time and some manage longer. So, but we have a range of 4 to about 10 hours. So that's why, and it is because of this change that we able to find out the dosage effect. But if the kids are not wearing the contact lenses, they don't really get the myopia control stimulation.
Sure. And then are there any sort of external cosmetic issues? So if somebody's looking at a child with the lenses on, do they see the lens array? And
No, this is a very nice design.
Right. So
you could see, yeah, it is like 1 millimeter diameter and 400 of them, but they only raise a little bit. Mm-hmm. So it's like 1 millimeter raised comparing to the front surface. So it's not noticeable at all. If I give you and did not tell you that it is a DIMS lens, you would not notice.
Great.
So you
Yeah.
special
No,
light
this is
after shadow.
really exciting. So I think this is really a way to go. So
What were the ages again of your children that enrolled?
The children are 8 to 13 because we pick this age that it is the highest progression rate because they are hitting the puberty. So axial length, whole general growth, all this will accelerate the axial length. So we're hoping to get the best myopia control effect.
So I was going to ask something similar to it. How is the age? Did you notice a difference between younger versus older
Yes.
subjects?
Yeah, so because the time is limited, I did not show the age relationship. But in fact, from our 2 years RCT, we noted that the younger children were not benefited as the older children. So young children still continue to have high myopia progression. We still need to find out the reason why. So, but this lens is now in the market for 2 years. So, and we have 1,000 data in our clinic that we are going to look at whether the lens will benefit the younger age group.
Thank
Fantastic.
you. We do need to move on. Thank you for that. Hopefully, if we have some time, we'll move on to a couple other questions. But we do thank Dr. Lam for that presentation. Our next presentation will be given by Dr. Augustine T. Power profiles of center distance multifocal soft contact lenses.
Thank you, Dr. Masak, for that introduction. So my name is Augustine Inti. I'll be presenting our work on the power profiles of center distance multifocal soft contact lenses on behalf of my co-authors. I'm a PhD student at the University of Houston. And these are disclosures. So as the first speaker mentioned, the prevalence of myopia is increasing globally. And in this graph here from this 2016 paper, it's expected that if current trends continue, then about half of the world's population will be myopic by 2050. And this is a problem because apart from the reduction in vision that myopia causes, it also increases the odds of other vision-threatening comorbidities such as glaucoma, cataract, and myopic macular degeneration. So because of this, several groups are looking into ways by which we can slow myopia progression and myopia prevalence. And one of these ways is with the use of center distance soft multifocal contact lenses. And what I have listed here are just 2 recent 3-year clinical trials which show the efficacy of center distance multifocal contact lenses in slowing myopia progression. And initially, based on results from animal studies, it was hypothesized that the myopia control effect from these multifocal contact lenses was due to the fact that they were able to simultaneously impose clear foveal vision and myopic defocus. So in this image from this recent paper, you see here that with a single vision contact lens, you have clear foveal vision, but then out in the periphery, the rays of light come to a focus behind the retina, which causes a peripheral hyperopic defocus. And this was hypothesized to be a signal for the eye to grow longer. However, with a multifocal soft contact lens, what happens is, again, you have clear central vision, but out in the periphery, because of the added plus power, the rays of light come to a focus in front of the retina, causing a peripheral myopic defocus, and this was hypothesized to be a signal to slow eye growth. And when you increase the add power, you have a more pronounced effect. However, like this illustration is from the Blink study results, the paper they published. And it was a study in which children, myopic children, were randomized to either a single vision or a plus 150 or a plus 250 add biofinity multifocal contact lenses. And what they saw from that research was that only the plus 250 add multifocal contact lenses was able to slow myopia progression when compared to the single vision contact lens. And also, quite interestingly, they just presented an analysis last week at AVO where they showed only a weak association between peripheral defocus and myopia progression. So what this suggests is that a linear dose response to peripheral defocus does not adequately explain the effects of multifocal contact lenses on axial eye growth. So they propose that probably exceeding a threshold amount of peripheral myopic defocus or some other mechanism other than peripheral defocus, such as contrast or chromatic hues, may be responsible for the significant slowing of axial growth that you see in multifocal contact lenses. But in any case, because of results such as from the BLINK study, several clinicians are prescribing these multifocal contact lenses for myopic children. So what we wanted to do was to actually measure and understand the power profiles of these contact lenses. So the purpose of our study was to determine the power profiles of commercially available multifocal soft contact lenses that are being prescribed to slow myopia progression. And we were also interested in analyzing any differences in power profile between different parts of the same contact lens design. So for instance, if you take a bi-affinity multifocal, is there any difference in the power profile between, let's say, a -1 and a -5 contact lens? We selected 3 contact lenses. They were selected because at the time we did a study, they were being used or studied off-label for myopia control here in the United States. So the first was the bi-affinity multifocal D with a +250 AD. The second was the Proclear multifocal, also with the +250 AD. And a third was the Natural View multifocal. So here we have the reported power profile of both the bi-affinity and the Proclear multifocal contact lenses. And here in the center of the lens, you have the distance portion so that the subject is able to see clearly. But as you go out into the periphery, there's a gradual increase in plasma to the edge of the contact lens. And here, this is an image from a patent application by Visionary Technologies. So we think this might be what the power profile of the Natural View multifocal is. They produce the Natural View multifocal. And here you see that right at the center of the lens, there's a sharp increase in plasma, and then the plasma decreases to create what the company describes as an optical pinhole. But these are manufacturer reported, and we wanted to see what actually is happening in the lenses when you measure them. So we took 2 lenses in one diopter step from -1 to -6. And for each power, we measured the 2 lenses and averaged. The lenses were initially stored in ISO standard PBS for 24 hours before measurements. And for measurements, we used the SHS ophthalmic, which is pictured here. The lenses were placed in a wet cell. The wet cell also contained the same ISO standard PBS. And then we took 3 measurements on each contact lens and averaged. We also measured the center thickness of each contact lens with the iView OCT, and then entered the measured contact lens, the refractive index, and other optical parameters into the SHS ophthalmic software to generate the power profiles. And because we're measuring the power profiles in a wet cell, the power was then converted to the equivalent power in air before analysis. So here's an illustration of the output you get from the SHS ophthalmic. This would be the contact lens, and each square grid here represents a discrete point at which the power is measured. However, we masked the central 0.5 millimeters because with this instrument, you get artifacts within this central portion. This has been reported in other groups that use the same instrument, and they also masked this central portion. And then also because all the lenses were rotationally symmetric, we took the power along the horizontal and vertical meridians and averaged it to generate the power profiles I'll be showing you. And additionally, because these lenses were expected to have very different designs, and because there's no standard on how to report on the add power of multifocal contact lenses, we defined the maximum add power as the difference between the lowest power in the center of the lens and then the most positive power anywhere within the optic zone. And this allowed us to capture the maximum add power irrespective of where it was located in the power profile of the contact lens. And then we used a one-way ANOVA and adjusted post-hoc t-test for analysis. So these are our results. The first one is with the bi-affinity multifocal. Just to arrange you, on the y-axis, you have the power, and on the x-axis, you have the radial distance from the lens center. And then each line represents a different power from -1 to -6. All the other power profiles will be of a similar output. And you see clearly that there are 3 distinct zones of the contact lens. First, you have the distance portion, which goes from the center of the lens to about a 1.6 millimeter radius. And then there's the intermediate portion where you see an increase, a sharp increase in plus power. And then there's a near portion, which goes from about 2 millimeter radius to the edge of the optic zone. And these lines just represent the peripheral curves of the contact lens. What we realized was that for the lower minus powered lenses, like the -1 and the -2, in the near portion of the lens, the plus bar continues to increase till the edge of the optic zone. However, with the higher minus powered lenses, like the -6, in the near portion, plus bar rather reduces as you go towards the edge of the optic zones. So here the peak plus bar is very close to the center of the lens, right here at around 2 millimeter radius. Whilst for the -1 lens, the peak plus bar is at the edge of the optic zone of the lens. And we don't know whether this would have an effect on the ability of these different pairs of the multifocal contact lens to reduce myopia progression. And again, for the Proclear multifocal, it's also very similar to that of the Biofinity with 3 distinct zones. The distance portion very close to the center. Then there's a sharp rise in plus bar in the intermediate portion of the lens. And then you have the near portion of the lens, where again, for the high minus powered lenses, you see the plus bar gradually reducing as you go to the edge of the optic zone. But for the low minus power lenses like the -1, the plus bar again increases towards the edge of the optic zone. Again, we have the same phenomenon where the peak plus bar for the lower minus powered lenses is at the edge of the optic zone, but it's close to the center of the lens for the high minus powered lenses. And finally, we have the power profile of the natural view multifocal, which you can see is very different from the first 2 lenses we looked at. For this lens, right from the center, you see an increase in the plus bar all the way out to an about 2.7 millimeter radius. And then the plus bar sharply reduces. And then for the lower minus powered lenses, after it reduces, it levels up till the edge of the optic zone. However, for the high minus lenses like the -6, the plus bar again continues to reduce. And what this means is that for instance, for the -6, you have a more minus power at the edge of the optic zone than at even the center of the lens. And again, whether this would affect the ability of this multifocal, this particular power to reduce myopia progression is unknown. And I think it would be important for that to be looked at. We also looked at the maximum art power across all the lens pairs for each of the brands that we measured. And we saw that the highest art power was with the natural view multifocal, which was around a +3.2. And then followed by the Proclear multifocal, which was around a +1.8 diopter. And then the lowest art power across all lenses was with the Biofinity multifocal with an average of 1.5 diopters. And again, over here in this table, we see that for the lenses, as you increase the minus lens power, so as you go from -1 to a -6, there's a reduction in the maximum art power. And this is consistent across all the 3 lenses that we looked at. And you have a difference of about 1 diopter between a -1 lens and a -6 lens for the same lens brand. And again, this might affect the ability of the higher minus powered lenses to reduce myopia progression. So to our conclusions, we realize from this work that the power profiles of these multifocal contact lenses depend on the label distance length power and the particular lens design that you are looking at. The highest maximum art power was found with the natural view multifocal, followed by the Proclear multifocal and the Biofinity multifocal. We also saw that the maximum art location varied based on the distance lens power for the Biofinity and the Proclear multifocals, but was consistently at 2.7 millimeter radius for the natural view multifocal. And we think it's important for research to be done to understand whether the effects of the maximum art power, the maximum art placement, whether it's close to the center of the lens or it's closer to the edge of the optic zone, and the distribution of the art power within the lens influences the ability of a lens to reduce myopia progression. So I'd like to thank Dr. Masaka and Dr. Hastings. They were very instrumental in helping us take these measurements. We've published these results in a recent paper, and you can just scan this QR code to read that paper. And if there are any questions, I'll take them now. Thank you.
Great. I think we have time for 1 or 2 questions. Augustine, I'll start with one. You had showed that the power profile is slightly different for the high negative lenses versus the less negative lenses. Like the -6, that power in the periphery tailed off. Is that a fact, like a manufacturing issue, or is it by design for some like visual function?
That's difficult to tell, but because it's consistent across all the 3 different designs that we looked at, it's probably because of negative spherical aberration, where as you increase the label distance lens power, you have more negative spherical aberration, and then that causes that reduction in plus power you see for the high minus powered lenses. So probably in manufacturing, they might need to control for this so that you don't see that tailing off in the higher minus powered lenses.
Thank you. I think Jim Schwegerling also has a question.
Yeah, so my understanding with the natural view lens was that it actually has like a very small region that has the power of the lens, and then outside of that it has very high spherical aberration that basically blurs everything going through the periphery of the pupil. So it's acting more like a pinhole effect than having like a true add power like the other 2 lenses that you described.
Okay. And also because we maxed the central 0.5 millimeters, if that's where the distance bar is, then we couldn't see it in our measurements, yes.
Thank you very much.
Thank you.
Our next speaker, Yongjun Lai, will speak on IOP monitoring soft contact lenses. Dr. Lai.
Okay, yes, thank you for introduction. I think one of my group member, probably Angelica, is in the forum now, and Dr. Campbell is not able to attend today, maybe later on in other sessions. So we are the group working on the soft contact lens for glaucoma intraocular pressure monitoring application from Queen's University at Kingston, Ontario, Canada. For this talk, we just want to share some of our work with you guys. And first, we want to give very brief reason why we need to do the intraocular pressure monitoring and how we use our soft lens to do that. And also, we want to show you how we make our soft lens and as well as the results that we used for the in vitro testing. We haven't get into the human trial yet due to the pandemic. We delayed our plan for almost more than a year now. Hopefully we can get that done soon in the next 6 months or so. Now, why we need to do the monitoring for intraocular pressure for glaucoma patients? We know glaucoma is a leading disease for blindness, and very importantly is the glaucoma disease is a irreversible disease. If you get diagnosed and they see your vision is lost, and then whatever treatment you can get, you are not able to regain better vision. So therefore, it's very important to get early diagnosis and get early treatment. And also the population of glaucoma patients is keep increasing nowadays, and there's a very large need for this technology that make some affordable and easy access technology for the patients. Now, most people probably not developing glaucoma disease may not really realize their vision lost, because the vision lost for glaucoma is really gradually from the outside vision and go promptly to the center. So when they really notice they have the vision loss, it's already a very significant vision loss already occurred. So that is a big problem. So therefore, we need to do the early monitoring to see or get the early diagnosis. Now in the clinic, right now, we are not really sure what really the reason caused glaucoma. We know what happened, but we don't know really the reason behind. But in clinic practice, the treatment is very often the early stage use medicines, or the surgical intervention. But the purpose for this is try to lower the intraocular pressure, which creates the pressures and depress the optic nerves. Now the problem or the challenge for the physicians is now the intraocular pressure for patients or glaucoma or people that under risk of the developing glaucoma, the highest pressure or intraocular pressure is not really able to measure it accurately. Okay, so in Canada, the physicians can only get the patients to the clinic to take one shot measurement every 3-4 months. So this is not really informative for physicians to make the decision how to treat their patients. And even during the day for patients, depends on their activities, depends on their postures and so on. Their intraocular pressures fluctuate all the time. So therefore, the frequent measurement or monitor of the intraocular pressure is very helpful. And therefore, it's very good for us if we can bring some technologies that can help physicians to measure their intraocular pressure more often. Now, how we can use the soft contact lens to measure? Now, the fundamental principles we based on is really based on the strain from the eye and basically the strain gauge, put it this way. We know when the intraocular pressure inside the eye changes and the pressure we're going to change or deform the eyes. On the back side, the pressure increase, we're going to press the optical nerves. On the front side, in the anterior chamber, the acute goes to the front anterior chamber and not fully observed. If they have glaucoma, basically accumulating pressures, and then they deform the cornea and the sclera. Okay, so basically they produce the mechanical strands, deform them. In the cornea area, is around 3 micrometers per millimeter mercury increment for the diameter. And in the sclera, it's much more. That is around 100 micrometers per millimeter mercury. So this is sort of the base effect that we make use of. Okay. Now, if we see those strands, we put the contact lens or soft lens onto the eye, and then part of those strands should be able to transfer to the soft lens. And in the soft lens that we made a microchannel inside, and we inject a flow type of liquid and inside the channel. When the deformation occurs in those contact lens, soft lens, and they change the volume of the microchannel, and therefore the shape of the channel will change, and the liquid is incompressible liquid, and they were going to refill the area that changed from the strain from the eye. So basically, they were going to change the location or change their lens of the field place. So this is the fundamental principle how it works. Now, once we know when the pressure changes, they deform the eye and eventually deform the contact lens, and the liquid we call the indicator fluid, basically is part of the liquid in the channel, they were going to move around. So by using image processing, and we are able to identify what the pressure particularly corresponding to whatever location. And then from there, we can tell the intraocular pressure for the patient. So the device, you can use cell phone or you can use your laptop or whatever that can take images for the patient. And then you may ask us how we make this. Here, just a very simple slide just show you. The contact lens in this case is not one piece. We have two pieces. One bottom piece with the micro channels molded into it, and the top piece is a smooth piece. So the two pieces are made. Right now, we are making the lens from the PDMS with 15:1 ratio. And we use the plasma surface treating to bind these two together. It look like one piece after they bind it together. And then the final step, we put the liquid or indicator fluid into this lens. We use the basically DI water or the distilled water with some food colors for the easier observation. Or we use oil, so it depends on the type of the background. So we want to choose. Now for making those two pieces, the top and the bottom piece, we use micro mini machine, make a mold. Basically, we have a top piece and bottom piece, and then we use molding. The thickness of the total lens, the thickness is around 250 micrometers. It's a little bit thicker than the normal contact lens. It's almost doubled of the normal contact lens, but it's much thinner than other, I think maybe just one compared to the one that on the market. It's much thinner than the one that on the market for the intraocular pressure measurement. So this is the process, how we make those soft lens. Okay. Once we able to get all of this done, we did quite intensive testing on the caloric eyes and also the animal model is the pulsar eyes. Okay. This is the general setup. We use a syringe pump and deliver the liquid or water into the eye, the model eye, and to control the pressure. And then we use a micro pressure catheter pressure sensor into the eye to measure the pressure, what really is. And then put the contact lens on top, and then we use the cameras and get the images to the computer, and then we can do the image process and measure the change of the locations, and that corresponding to the measured pressure. And then we are able to correlate the pressure, intraocular pressure, and the movement. So basically from the baseline. Now so far we have three versions of designs. The early first version we call it zigzag because of the channel. It's not straight, it's a zigzag shape. In the center part, we just leave that as for the region, and then the channels is on the side. The testing we have done, basically we use multiple contact lens with one eye, and also we use multiple eyes with one lens. So basically see how universal performance we can get. Now for both type of testing, we see pretty consistent measurement. The sensitivity, we can get around over 25 micrometer per millimeter mercury. So this is how much the liquid can move versus the pressure change. And both of them are pretty decent, give us very decent linearity and coherence. Also, we did a little bit testing and see, sometimes we see when people drink, for instance, drink coffee or something, a lot of drinks, and their IOP, we're going to surge up probably by 5 millimeter mercury or so. So we want to see if we really increase the pressure very dramatically in a short time, surge it up, and see whether our sensors able to respond that or not. So we did a little bit testing, and with the pressure go from 10, all of a sudden go to 36 and back and forth. many times, and we see whether the sensors able to respond and also fully retract back to the original position. And we found this very interesting for this sensor, for this contact lens sensor, and the recovery back or return rate, which means the flow go to the high pressure and go back to no pressure, they almost fully recovered with a slight difference. And that basically is caused from the surface when we do the machining for the channels. And some of the area, the roughness probably still need to be improved, and they retain a very small amount of liquid in those rough areas, and therefore they are not fully able to return back to with the main strain. So that gives a little bit difference. And then we made another type of design, just single spiral, and put the liquid in. In this design, we found we have get a much larger sensitivity, almost 3 times higher sensitivity, but however, the return rate is not very great, which means they keep moving in one direction, not fully return to the original position. And also we tried the double spiral, this is the third design. This one is sort of the modifying the other two. It gets in the medium, has very good improved resolution, get 44, almost double the original one. And the return rate is 98%, it's much higher than the second one, and even higher than the first zigzag one. So this gives us a very good sense of the design that we can carry on for the human trials for the next step. So they compare these 3 of them, and we decide the double spiral one, which is much compare the resolution and the return rate, and I think it's much more reliable and performs better. So we decide to choose this one to go ahead for the future work for the commercialized prototype, and we already contact with one company in States for the final fabrication for our human trial products. So I just want to show you guys one short video that we are using a Porsa eye to move the liquid from 10 to here. If you see the liquid here from 10 is here, 10 millimeter mercury, and then move to 36 millimeter mercury here, pressure changes. And this liquid move from one end to the other. It's around 1.5 millimeter movement. So you can see clearly, even if you have a nice camera, of course, you can capture it. Even you can use your naked eye to see those motions. Okay, so overall, we say this is very promising process, and it's simple and it's very effective. So therefore, we are going to go a little bit further to do some clinical trials studies, and probably we're going to report later on. All right, thank you. If you have any questions.
Yeah, thanks very much. Maybe time for 1 or 2 quick questions now. Bin Young?
Sure. Dr. Lai, thanks for the excellent presentation. This is very interesting technology. I have just one question, like more practical questions. So when people wear this lens, right, they need to blink every several seconds, right, to, you know, make the tear surface uniform. So does your technology have the capability of dissociating that change from the real IOP change?
Right. It's very interesting question. I think this also J&J, Johnson & Johnson, their R&D manager asked the same question for us a little while ago. So when people blink and how we can reflect that. To be honest, at this moment, we haven't really able to consider or to invest how that can change or how that can associate with our measurement. But I think if, because we are doing the imaging processing, so if they blink, the only thing that we can think of is the contact lens may shift location a little bit because you're blinking. Because of the location changed may influence the measurement slightly, not because of the pressure of the or the strength of the lens. Also maybe because of the pressure that changed when the contact lens is located in the different locations, the strength is transferred to the contact lens may slightly different. I think that probably can be one of the things that we need to pay a little attention to. But from the image processing point of view, it should not be a problem because only when your eye open, the camera can take images. When you blink, and that automatically the images taken will be rejected because it's not clear and they reject that image.
Thank you.
Thank you.
Jason Porter has a quick question.
Yeah, thank you. This is pretty interesting. I have another question in terms of being able to accurately measure the IOP. I'm wondering, to what extent do you think corneal thickness may play a role in the measurement? There may be different biomechanical impacts, right? If you have a thicker cornea versus a thinner cornea. And I'm wondering if you have any idea on how sensitive the technique might be. Thank you.
Good question. Thank you, Jason. We did a statistical study work on probably 35 eyes, port-size eyes with our contact lens to measure whether the thickness of the cornea, also the size of the eye, whether influence the measurement. And we find out actually there's no correlationship from our measurement. So it's not really, it's a little bit different from the Goldman standard measurement. So it's on the thickness of the cornea. It seems our contact lens is not really depends on the thickness of cornea. The reason for that, I think, because the sensing unit is really off the cornea. So the sclera actually has more deformations, which I think the strain transferred to the sensor is from the sclera, not from the cornea. That's what I understand so far from our testings, and we didn't see any correlations for those.
Thank you.
I'd like to ask a question for Dr. Lam. I think you showed, in your earlier studies, you used the concentric, radially symmetric pattern to control the myopia progression. And I believe you showed the 25% effectiveness with that. And
Yeah.
now with the DIMS, you, presented a substantially improved efficacy with that, lenslet design. Can you tell us a little more about potential optical mechanisms, why DIMS shows so much more improvement in efficacy compared to the traditional concentric design?
Yes. First of all, the wearing time is a big difference. So I have shared in the presentation too that children can wear 15 hours, up to 15 hours of spectacle lens comparing to 3 to 8 hours of contact lens. So that's one thing. And then with this mid-periphery multiple lenslets, we also found that actually it changed the overall eye shape. So for usual myopes, when they have myopia progression, there is an asymmetrical expansion of the retina. But when they wear the DIMS lens, there is an overall uniform expansion. So that is really affecting not just at the central foveal region, but also over the whole retinal shape. So we are going to publish the data soon.
Thank you.
You know, I also have a question for you, Dr. Yun. Maybe a comment. This lens that we have designed, so we also try it ourselves, and being a presbyopic,
Yes.
so this diffrax concept is very useful for presbyopes. It's so good. You know, this lens as a presbyopic lens, I can see so well for distance, for near without much change. So I'm sure your lens will work the same way. So congratulations.
Oh, thank you. Well, I can't wait until, other people actually experience this, type of concept, this lens.
Yeah, it's great.
So we just need to get the IRB approval to get the study going.
Right.
Great. Well, I do think out of kind of respect for the time of the session after us and then the attendees, we'll go ahead and move on to our second session. But we'd like to thank the speakers for taking their time to be here today and give us these presentations. They were all very wonderful. Thank you. Our second session of today's webinar is titled Advanced IOLs and Presbyopia Correction. And this session will be moderated by Jim Schwiggeling and Ronald Kruger.
Okay, thank you very much, Jason. I'll go ahead and let Jim make some quick comments as well as a co-moderator, and then he can introduce me as the first speaker.
Sure, absolutely. So yeah, so today, I think we've heard some exciting stuff about presbyopia correction and the last panel, and so hopefully we'll continue with that. Our first speaker is Ron Kruger, and I always really look forward to Ron's talks because of his expertise. He really gets access to a lot of the advanced technologies that are coming down the pipeline, and I'm sure we're going to see some really cool stuff. That hopefully will be coming here in the near future. So without much further ado, Ron Kruger with current and future trends in presbyopia correction.
So my initial talk to start things off is going to be on current and future trends in presbyopia correction. And this is really a section on advanced IOL technologies, but it really is a session on presbyopia overall. And a big part of that's IOLs, but there are other technologies which you will see as we go through this, this presentation. Just as a disclosure, I am a consultant with Alcon, an investor in RxSight, and an investor in Smart IOL. So I'll start off with this initial slide that said, did Moses have presbyopia? And in the scriptures, it says in Deuteronomy that Moses was 120 years old when he died, yet his eyesight was clear and he was as strong as ever. So whether he has presbyopia or not, we don't know, but his vision was quite clear. And understanding that both presbyopia and cataracts are number 1 and 2 in terms of eye disorders of aging, we could presume that he must have had early cataracts, but yet they weren't really bad. So it's sort of a little bit of a mystery. Usually that's an issue by the time you're 120 years old. It's mainly due to the age-related stiffening of the lens and sclera for presbyopia. So how do we currently handle presbyopia, at least surgically? Obviously, the things in white are how we're doing things with spectacles and contact lenses, but surgically, we either do a monovision correction, which can be done in an IOL or LASIK, multifocal correction, which can be done in IOLs or in some cases LASIK internationally, or in an accommodating or movement-based IOL. And I reduced that to the 3 M's of monovision, multifocality, and movement as a way to get that extra power for near vision. So I'll just start by saying, number one of the big things that predicate the type of procedures that we consider has to do a little bit with the age-related lens dysfunction. And that's just to say that there's a dysfunctional lens syndrome scenario where we can grade that in stages, where early presbyopia is at stage 1 of 40 to 50 years old. It's when the lens of your eye begins to lose some flexibility. It's the reason a lot of people start using reading glasses at this time. And there really isn't early cataracts at this point. So it's still very reasonable to do a laser vision correction type procedure with monovision, or in some cases, maybe consider a refractive lens exchange for high levels of ametropia with either multifocal lens or monovision scenario. Stage 2 is presbyopia with early light scatter, more like 50 to 60 years old. You get a little bit of the optics beginning to degrade, image quality begins to diminish slightly, progressive yellowing and light scatter might occur, and you might consider, again, laser vision correction with monovision in these cases, but more likely to start thinking about a refractive lens exchange with either a multifocal type of lens design or a monovision scenario, or maybe even a movement-based IOL. And then finally, we get to stage 3, which is greater than 60 years old. You pretty much have some light scatter and early cataract at that time. There's more yellowing overall of the lens and the scatter as well. And it might even affect the patient who has LASIK in terms of contrast and some of the quality. So it's going to be more likely that you do cataract surgery or refractive lens exchange with a multifocal or monovision scenario or movement-based lens. And maybe you'd still consider monovision laser vision correction in some scenarios. So that's really the number one consideration of the age-related reasons why we pursue one versus another type. But then there's also lifestyle preferences. And I like to use this example of 3 personalities that might be quite different in the way they view things. So we have the night driver, or so he says, who's very active at night and has a large pupil size. We've got the chemistry professor, where most of his work is in the intermediate range. And then we have the fashion designer, who is an active woman who wants good near vision and to be glasses free. So what we might consider for the night driver is pseudophakic or laser vision correction monovision, because he can wear glasses whenever he wants and he has no compromise in terms of glare, halos, or other dysphotopic phenomena from the lens that might be placed in his eye. The nutty professor might be looking for an extended depth of focus lens where he gets good vision at both distance and near, and helps him with some of his work that's in the mid-range area, kind of not so much really up close, but more mid-range where it's functional for his lab work. And then you've got the fashion designer who really wants to have some kind of a multifocal lens design because she really wants it all. She wants the distance, she wants the mid-range, she wants the near, and a lot of those lenses will give her that flexibility so that she doesn't wear any glasses at all. Now, what happens if you mix them up and you happen to pick the wrong type of solution for that particular patient? Well, in the case of the night driver, he's going to have unwanted glare and halos, and it's going to make his life miserable. The chemistry professor is going to complain because he can't see working up close at his lab to do most of his work if he has the wrong lens. And of course, the fashion designer might complain that I can't see well up close without glasses, and glasses is a no-no for her. So it's very, very important to understand lifestyle, and questionnaires can be helpful for that. And the number 3, I kind of talk about a little bit of maybe this trend of simplicity versus complexity. As we offer more complex solutions, we can drill down on just mechanisms that work better. But simplicity is always a good thing when considering surgical corrections. And ultimately, the question is, what's going to provide the greatest satisfaction and the lowest risk of dissatisfaction to your patient? So from there, I'm going to kind of move a little bit more into future. This is kind of a little the current. More of the future has to do with considering some of these things of simplicity, speed, and safety versus complexity, quality, and personalization. And I'm going to walk through that of drops to lasers to passive implants to new energy sources and even to active implants. Eye drops for presbyopia correction have sort of hit the market with some attention because it seems to be a very easy solution if it can really work. And the pharmacologically induced pinhole effect seems to be one of the biggest ways. However, there's a Novartis product that is looking to place drops that decreases lens stiffness. And then nanodrops has been popularized a little bit and is still being investigated to change the refractive index that might help patients overall. So looking at miotic drops that really dominate the pharmacologic pathway, you can see a number of companies have a type of a single agent miotic that can be used in low concentrations tolerably. This one company here, Visus, does a combined mechanism using both a carbachol and a bromonidine, and that's the brimacol that has some enhanced efficacy. But basically, the miotic drops increase the depth of field by the pinhole effect. They're not without their side effects because you can get headaches and brow aches, and that's why we tend to use low concentrations. And the single agent miotics may have more of an issue with some of the side effects than the combination drops. And so combinations may be things of the future. Here again is just showing the prolonged duration that's coming by one of the combination drugs using bromonidine as well as a carbachol that seems to give enhanced effect. Lens softening with the EV06 is something that Novartis has been pursuing. It's actually a lipofulvic acid choline ester, which helps to break disulfide bonds in the lens. And in some early clinical trials, you can see from pre-op what the best corrected near vision is to the best corrected shift to better vision post-op after 90 days, showing that there's some promise, but we still need to see further results with that in the future. And then finally, refractive index change is the concept of using eye drops composed of synthetic nanoparticles that can be instilled into the corneal epithelium to modify the local refractive index and induce a temporary change in the pathway of light in a controllable fashion. So temporary refractive surgery, kind of like a refractive Botox. The concept is that you can measure this, and you can do this yourself. You can do this at home. You can measure your refraction with a smartphone. Technologies now exist that will give you a refractive error. You can then have a little handheld laser that creates an optical pattern. It's a painless superficial laser etching. According to the correction that's needed, it's only in the epithelium of the cornea, so it's not a permanent etching. And so if there's an error or something, it can easily just not instill the drops, but it does allow for little craters for the nano drops to then infiltrate and populate in a certain refractive pattern that might ultimately give the desired correction. Here shows a little bit of a scanning electron microscopy of these nanoparticles. They're tiny hyper-refractive balls, 20 to 70 nanometers in diameter, and you can see where they tend to fill into the stromal crevices in a specific pattern. Some of the early outcomes, and this is not in patients, but just in cadaver eyes, would show that you can instill the drops. It does not change the keratometry at all because there's no curvature change, but the refractive index can get 2.75 diopters of plus power for reading if you wanted to do that in one particular eye. If you're going out in the evening and you want to give temporary monovision, you could potentially do that. Let's go on to presbyopic laser vision correction. You know, that's something that's going to continue. LASIK and SMILE blended vision, maybe things that more of the future. Refractive index changed with some different company products. And then, of course, the idea of putting tissue implantation like a inlay, but not a synthetic inlay, actually using human tissue, which is maybe more something for the future. Lyric is a procedure that is being investigated. Scott McRae has been involved very much with this, but it's the idea of using sub-threshold femtosecond lasers, which can make small refractive index changes in the cornea and give some duration of effect of change in refractive error for near correction or presbyopia correction. There's a reduced fear because there's no real incisions or flaps, less keratocyte death, less risk of dry eye, ectasia, and some otherwise good superior quality. Blended depth of focus monovision is certainly popular, and that can be done with laser vision correction techniques. Just enhancing the overall depth of focus is a great way of doing that, and trying to make it more of a blended vision between the two eyes and monovision is an acceptable way. And then finally, Allotex is a commercial entity that's looking at implanting tissue for surgeon modification of ultimate shape. It can be used for hyperopia, but also with a very small 1 to 2 millimeter lenticule can correct presbyopia, and you can sterilize the tissues so that there's no chance for rejection or infection. And then finally, in the last couple categories here, presbyopic extended depth of focus IOLs are really exploding the market. You know, we sort of have looked at EDOFs and trifocals as being sort of a mainstay of how IOLs are doing it today, and we're going to see more of that as we go to the future. Even the concept of an extended depth of focus phakic IOL that we can then implant, and it might be easier to remove if there was some dissatisfaction there, and then light or laser adjustable IOLs can also be entertained. With the EDOF lenses, they now expand into a category of multiple subcategories. There is a diffraction-based EDOF lenses, such as been initially represented by the Symphony lens. The diffraction ones, there's a refractive ones. The new Vivity lens by Alcon is one particular model of that. And then there's even the pinhole concept, which is rather robust. It has many advantages, maybe less glare and halos. And here you can see even just some of the overall comparisons of trifocal lenses, extended depth of diffractive lenses, and the pinhole lens, where you can see there's really good quality in each of them, especially the pinhole lens. So we may see more of that in the future. And you can get a good diopter and a half of refractive effect with the pinhole lenses. A phakic or piggyback presbyopic IOL is certainly something we may see in the future. ICL is now about 20% of vision correction in China, which is quite amazing that there's such implementation of that. And it can be done as a very quick procedure because the Chinese have made that very adaptable. Having an extended depth of focus ICL with a broad depth of focus overall allows for further reading capabilities, and it's easy reversible, as you can just remove that ICL, much easier than removing a lens implant. There's different models that may even have multiple ads. This is a trifocal one, an IPCL, that's also been popularized and is early available in Europe. Light and laser adjustable IOLs with adjustable blended vision is a way that you can kind of control this to titrate it for a patient where you might have a more negative spherical aberration, extended depth of focus, and a non-dominant eye, still allowing for binocular summation and giving a good range that can all be adjustable after an IOL is implanted. So it gives us some good flexibility. And then final category is that of presbyopic pseudo-accommodation restoration, trying to really mimic that, that mechanism of accommodation as much as possible to really try to get the maximum restoration. And that's based on pupil movement, electro-optical IOLs, biomimetric accommodating IOLs, softening of the sclerotic lens and sclera, and then even remote reflective IOL technology. So just looking at the first thing, the autofocal movement-based pupil size detection of the Alenza lens is something where it detects what your pupil is. When you're reading up close, your pupil gets a little smaller. It'll actually electro-optically change the overall power of the lens with a chargeable battery that's within the lens itself to give you the near. The patient really doesn't need to do much, but just take a look and have that pupil respond in a way. And then there's this rechargeable power cells that when you're sleeping at night, you can recharge it and continue to use it. So it's using its power, not from so much from the accommodative mechanism of zonules, but from the actual elements in the lens. Lens curvature changing IOLs, such as this, is showing that within a flexible bag and multiple lens elements, you can see a fluid-filled optical element that changes with accommodation to give sufficient power. And this is over a very broad range of good optical quality in comparison to what we see here in the blue line of a PanOptix lens that gives you distance, mid-range, and near. You can get even a much more broader modulation transfer function response because of the movability of this to whatever desirable range that you need. And this really goes along with the concept of movable IOLs. The single optic movable lenses have really very limited accommodative capability because there's not that much movement in the residual capsular bag, and there may be scarring as time goes on. Some of the dual optics lenses have been popularized for greater range, but may also lose some effect. And if we can see more change in lens surface curvature with future accommodating type IOLs, we can get much broader range. And if we can avoid some of the scar tissue, we may get more successes in the future. With that, I wanted to kind of show this brief video of a new technology, new energy source to ophthalmology, which is selective shockwave therapy. And this selective shockwave therapy can be used for multiple treatments, but you can apply this very localized micro shock waves to the sclera and to the zonule and to the lens in order to soften those areas to then restore some of the otherwise lost areas. And you can use this for glaucoma and other reasons too. But this is new technology we may see in the future that could change the way we do things with presbyopia correction. And then finally, that of the smart IOL, which is super magnification and remote reflective technology. It's the concept of a multiple element IOL that has coatings within the IOL made of different semiconductor materials with nanoparticles that can be tunable, that you can turn them on and off in terms of their reflectivity. You can have an external control of the focus, so you can remotely activate the coatings to be reflective using a smartphone. So you can turn on a coating, it allows the path length to increase, and that would ultimately change the power focus based on the shortening or lengthening of the path length to allow for different refractive corrections. And you can even add an additional element of a non-refracting material that can also be tuned on that might help with magnification. So somebody with age-related macular degeneration might be able to get a larger image by just tuning it into their cell phone. And as it is now, about 77% of Americans and about half of the world's population have smartphones. So this is the kind of things that we'll see more of as technology is adapted to patients in the future. So in the future, as a summary, drops are going to provide the least invasive solution for presbyopia in the future. We're going to continue to see work in this area. Laser vision correction with blended monovision will still remain as an option, especially for lower age presbyopes. Tissue implantation will replace synthetic inlays because of the greater compatibility. Extended focus IOL solutions are going to have multiple expanded options. We've seen that explode in the last year or two with a whole new concepts for extended depth of focus, which I think Damien's going to talk about in the next talk a little bit. Combination restoration is really the next frontier as much as we can tackle that. And smartphone remote access is going to bring back control to the patient in the future. And so when it comes to simplicity versus complexity, we're going to have to judge for ourselves what really works the best for patients. And this is the late George Waring III, back when we were doing debates with the ISRS, showing him in rare form at that moment. And I thank you all for your attention and leave it open to any questions that you might have.
Great. Thank you, Ron. So just, one quick question for me. So in the US, we tend to be pretty conservative about refractive lens exchange compared to other parts of the world. Do you see that changing as more of these technologies become available so that, people in their 40s and 50s, are taking advantage of it and don't have to wait till they get cataracts?
Yeah, I think a lot of the explanation for that might have been that some of the lens designs that we had in the US were not as robust as the rest of the world because the FDA was slowing us down a little bit at introducing those. But we're seeing more and more of those lens designs come. It's a viable option for people to consider with different multifocals and EDOF lenses. But there still is a little bit of a love affair with laser vision correction in the US, even in some older patients. And so it's just has to do with trends. We'll see what happens as the future goes on, but it's still viable for laser vision correction, even for 50-plus-year-old patients, even some 60-year-old patients may want to do it for smaller errors.
Okay, so our next speaker will be Damien Gattinel. And today he's going to be talking about the spectrum of multifocality and extended depth of focus.
I would like to thank the Wavefront Congress Committee for inviting me. I look forward to seeing you in person very soon. I would also like to thank my co-authors, and these are the financial interests relevant to this talk. The number of non-monofocal IOL models available has grown from less than 20 to over 100 in 15 years. A new category of implants, known as EDOF, for extended depth of focus, is accompanied by a rich lexical field and arouses the joint interest of manufacturers and specialist practitioners. However, we can detect some antagonistic trends these days, that of laboratories that compete in marketing to stand out, and that of practitioners who try to establish a more rigorous taxonomy of these lenses on a rational basis. The purpose of this presentation is to clarify the contours and the principles really brought into play by these innovative optics, the existence of which seems to be justified by the same mantra, reducing photic phenomena while improving patient satisfaction. From a historical point of view, EDOF lenses have recently appeared in the galaxy of so-called premium lenses. 2005, with the introduction of the first apodized bifocal implant, and 2010, with the presentation of the concept of the diffractive trifocal lens, were important milestones. It was in 2014 that the first lens called EDOF was introduced by its manufacturer. There is no doubt that the induction of a large depth of focus without a joint increase in halos was the main issue of the EDOF concept, with a clear desire to distance itself from a concept of a diffractive lens, which was reflected in the use of the term Echlet rather than diffractive grating. The notion of foci was also banned for the more advantageous notion of a useful continuum of focus. A more functional definition, but a more modest, at stake, has been proposed by the AAO. A low visual acuity of 20/30 with an additional half diopter of defocus than for a monofocal IOL. This definition is functional and does not prejudge the mechanisms involved. In photography, depth of field is a characteristic of the images produced. It is adjusted for artistic purposes, for which it is often reduced, so we get a nice background blur, also called bokeh. The easiest way to control depth of focus is to reduce the aperture of the diaphragm as shown in photos taken of the same pattern by opening and then closing the diaphragm. In clinical practice, blur is rarely considered artistic, and the aim is rather to increase the depth of field as much as possible. This classic system, like the pinhole principle, has been used to design IOLs which exploit this reduced aperture or pinhole principle. This process is effective as evidenced by the defocus curve, which shows an increase in the depth of focus on either side of the area of maximum sharpness. If one wants to avoid reducing the diameter of the admission pupil, one can vary the power within the aperture to increase the depth of focus. This variation can be obtained by various refractive and/or diffractive processes. Because contrary to what the semantic findings of manufacturers might suggest to designate these processes, it is always for the light propagated towards the retina through an IOL to undergo either a refraction phenomenon or a diffraction phenomenon. First EDOF lens was thus introduced as an apparently non-multifocal IOL, this argument being deployed for both to promote the innovative nature of the IOL to that attributed to low numerical aperture optics, without reference to the induction of additional diffractive foci, while providing correction for corneal chromatic aberration. Stung by legitimate curiosity, we could not resist the urge to study more closely, that is to say, on an optical bench, this very first EDOF lens. For that purpose, we varied the wavelengths used to obtain contrast modulation curves as a function of defocus. In the green, the MTF curve showed peaks separated by a divergence slightly less than 2 diopters. The blue light curve also revealed the presence of 2 distinct peaks of varying intensity, shifted from green by a difference about -1 diopter. The MTF curve in red light had an aspect symmetrical to that of the blue curve and was shifted by +1 additional diopter. On this optical bench, this EDOF implant clearly appeared to be bifocal in nature, with an effectively reverse chromatism that is more powerful in red than in blue. This type of reverse chromatism is generally induced by diffractive grating with positive addition, as shown schematically on the right side of this illustration. At this stage, it may be useful to recall 2 fundamental properties that govern the optical effect of diffractive gratings. One depends exclusively on the width of the steps. This is the degree or the power of the addition. The other depends exclusively on the height of the steps, which modulates the optical path difference and is therefore sensitive to wavelength. When this modulation is less than a given wavelength, only part of it is diffracted. Conversely, when the modulation is greater than a given wavelength, all the corresponding incident energy is diffracted. With a conventional sawtooth grating, the height of the steps is designed to diffract towards the focal point of order 1 about half of the energy in the green. The other half is not diffracted and constitutes the 0th order. If we increase the height of the steps, we can induce a shift with total diffraction of the visible incident light in the order 1 and the order 2. The study of the diffractive profile of the EDOF IOL, renamed Echlet by the manufacturer, is demonstrative. First, the width of the steps is equal to that of the diffractive cycle of a trifocal implant obtained by superimposing 2 bifocal gratings. It therefore provides information on an addition of intermediate vision, approximately plus 1.75 diopters. As for the height of the steps, it is also greater than for the trifocal diffractive IOL, because it is adjusted to modulate in an appropriate manner the chromatism in visible light. That is to say, diffract all the incident visible light by extinguishing the 0th order of diffraction. Mastery of these concepts makes it possible to design a lens that favors far and intermediate distances, which is one of the main issues in the specifications of an EDOF implant, while inducing a 3rd focal point with less energy for near vision. Such a lens can be described as an EDOF trifocal hybrid lens. In addition to EDOF lenses, we investigated the relationships between the profile and optical properties of other diffractive trifocal lenses and published our results in the JCRS in 2019. There are other interesting concepts for so-called EDOF and multifocal IOLs. Sinusoidal implants get their name from the smooth sinusoidal aspect of their diffractive grading. There is a more intuitive way than the equation for this profile to understand the basics of how it works. If we consider a sinusoidal grading as the juxtaposition of two sawtooth gradings, we then obtain a diffractive system with an addition of positive power, order +1, for the near focus, and in a more original way, an addition of negative power, order -1, which will provide the energy for the distance foci. The 0th order, that is non-diffracted light, is then dedicated to the intermediate foci. Sinusoidal networks naturally tend to induce an equal energy dispersion for the far, intermediate, and near foci. In addition, the far foci of the IOL consists of light diffractive in a negative order, that is divergence. It causes an increase in the positive longitudinal chromatic aberration. This is added to that of the refractive carrier optic, and this is not necessarily desirable in this context, and may give the halos an appearance of colored fringes. Now, multifocal refractive IOLs use a technology that is certainly easier to understand theoretically, but also in practice, since a vergence map makes it possible to identify its main characteristics. This IOL was designed with a rather central distribution of the areas dedicated to induced near vision. Wavefront analysis reveals an increase in both positive 4th and 6th order spherical aberration. Here is another model that uses an inverse distribution with central far vision and near and intermediate vision in the paracentral area. Without surprise maybe, the coefficients of the aberration modes are of negative sign. Also, without surprise, sectorial IOLs are asymmetrical and therefore induce an increase in the coefficients of odd higher order modes. Finally, let's come back to EDOF IOLs. We noted that the first implant marketed under this name was diffractive. Currently, the trend is towards the introduction of non-diffractive lenses generating negative or positive spherical aberration, and technology also referred to as non-diffractive, but of wavefront stretching, even if the presence of a plate of height close to 1 micron on that lens represents a potentially diffractive element. Seven years ago, we compared the main multifocal IOLs available with the first trifocal IOL using contrast modulation curves as a function of defocus for different pupil apertures. That was made in monochromatic green light. These all bi- or trimodal curves had the merit of showing that the qualifiers of bifocal versus trifocal were not usurped. A comparison of different EDOF lenses in white light with a cornea devoid of spherical aberration reveals some disparity in contrast management over varying defocus ranges. We note a frequently bimodal character, that is to say a double peak appearance for this opening of 4.5 millimeter. For a smaller pupil, these curves are slightly merging, but retain a rather heteroclite, often bimodal aspect. The differences are less pronounced on this diameter with the monofocal reference curve. For comparison and reference, a curve obtained with the EDOF trifocal diffractive IOL is reported. It seems desirable that manufacturers disclose in a more detailed and rigorous manner the principles involved in the creation of multifocal and EDOF lenses. These two terms also seem to overlap widely, whether at the level of certain defocusing curves in vitro and principles nicely dressed in semantic terms which cannot, however, be more prosaically than a combination of refraction and or diffraction. This should allow surgeons to make a more informed choice of current technologies and to compare them objectively. Thank you very much for your attention.
Great, thank you, Damien. Just a quick comment here that some of the lenses that you have shown don't meet the Academy of Ophthalmology's definition of EDOF lens, even though they call themselves EDOF lenses. So I just want to make people aware. It's just because it's in the name doesn't mean that it's, it's given that effect. And I wonder if you have any comments for that, because it seems like a bit of the Wild West in the literature these days on what EDOF is.
Yes, you are perfectly right. I think we need a more stringent classification for those IOLs. And in Europe, as you know, we are overwhelmed by those new lenses, which manufacturers usually tend to not label specifically as multifocal now, because this is in most people's mind halos related. So the graal here would be to make a lens which would provide you with the largest defocus depth of focus possible without any glare, halo, etc. And they use various concepts that they again, as I said in the talk, call differently. And EDOF is the new hype because again, it means something like better than a monofocal, but not as good, maybe at the near as a multifocal. But still, if you have some luck or a patient who really favored intermediate vision over near, you can be successful and have a patient free of halo and glare, which again remains to be demonstrated.
Mm-hmm. Okay, great, thank you. I think we'll move on to our next speaker here. So next up is Scott McCrae, and he will be talking to us about patient-reported outcome measure for premium IOLs.
So thank you, Jim. So in an attempt to tame the Wild West of multifocal and premium IOLs, I'm going to give you a talk about a large study that's being conducted with the American Academy and the Food and Drug Administration, as well as a number of the major intraocular lens manufacturers who've been helping to participate in defining some of the subjective responses that patients have. And this is a preliminary report in terms of this. So this is the preoperative data on over 700 patients in a large study that I'll describe over the next few minutes. We're still collecting the postoperative data and analyzing it. So unfortunately, I can't give you that information. This is as you'll see, it's a rather massive study, not only in terms of the number of patients, but also in the width of the information that we're collecting. So this study was generated because we really don't have a validated questionnaire for all these different studies that are being done. Each individual company is actually providing a questionnaire to patients. We're getting lots of information about visual performance with objective measures in terms of our classic measurements of contrast sensitivity and visual acuity, but we don't have validated information in terms of how our patients are responding to these various intraocular lenses, whether they're monofocals or premium lenses. So in an attempt to do this, the FDA worked in conjunction with the American Academy of Ophthalmology and reached out to the industry And we've been developing a patient-reported outcome measure for premium IOLs. And this helps us support device applications in terms of the regulatory application and standardizes it, and also other regulatory related activities, as well as, I think for us as clinicians, it aids us in doing research where we're comparing apples to apples and oranges to oranges, and helps us with quality improvement activities. So this study was done in conjunction with the FDA and the Academy. The Academy served as an intermediary. The RAND Corporation did the actual data collection, and the University of California Biostatistics Group is analyzing the data and providing that in conjunction with the advisory group. We all are familiar with the many different lenses that have come on the market in the United States. There are even more internationally. It's a little bit overwhelming, as Damien pointed out to you in the last presentation. And this study in particular focused on the premium IOLs that have been approved in the United States for this study. This is the advisory committee, which consisted of both industry, particularly regulatory members, as well as the FDA, as well as some members of the Academy. The Academy task force members are shown on the left. We want to thank especially Gunyang Yun and his team here at the University of Rochester for helping us with the illustrations that you'll see, the pictures that you'll see in just a moment, as well as acknowledging the FDA members and the terrific help that we got from the industry advisory group as well. So there were developmental steps to this very large study. First, a literature review, then 13 focus groups were conducted on 93 patients. 87 patients spoke English, 6 were Spanish speaking. There were 19 cognitive interviews with 14 English interviews and 5 Spanish interviews. This served as the basis for how we actually labeled the pictures that we'll show you in just a few minutes. So we developed the language to describe what the patients were experiencing from these focus groups. So it was in the patient's own language, basically, that was guiding us. Then we went out and did the field test, and then it did a preoperative and a 6-month postoperative study. In the 6-month post-op study, data is pending. The advisory group served in terms of giving feedback throughout the entire study, and we're still very actively involved in that. So in terms of the actual study, the patients were 45 and older. They would complete either an English or a Spanish survey, and then they were scheduled for binocular implantation. We always used the same intraocular lens in the second eye, so there was no mix and matching. We also included a monofocal group to give us some control information. There were accommodative lenses, spherical EDOFs, spherical multifocals, bifocals, and trifocals, as well as toric lenses, monofocal, accommodative, and EDOF, as well as multifocal lenses that were included. These were only lenses that were approved by FDA in the United States for this particular study. The dominant eye was targeted for emmetropia. The other eye may be targeted for emmetropia, but one could create up to 3/4 of a diopter of myopia as a target. The potential visual acuity of 20/30 or better was required after cataract surgery for qualification for doing the questionnaire at that 6-month gate. So the field test collected the first and second eye intraocular lens implant date, as well as the type of lens implanted in the right and left eye, binocular, corrected and uncorrected visual acuity is also recorded. The refractive error was recorded both preoperatively and postoperatively at that 6-month gate, and the surgical complications as well as postoperative complications were recorded. So the dysphotopsia, one of the problems that we have, and we don't have a lot of information on this because we don't have the post-op data at this point, but the dysphotopsias really aren't adequately assessed with the current patient-reported outcome measures that we're dealing with. And one of the objectives of this study was to get a handle on that, to improve that. And so we wanted to develop a questionnaire to better measure dysphotopsias and objectively measure that in terms of their subjective response. This is the flow chart of the visual disturbance and symptoms following cataract surgery. You'll notice on the right are the entopic phenomena, which also included floaters. These are really confounding variables. So we included them in the study because they're so dominant in the population, and we wanted to sort that out when we actually did the study. And then we looked at the dysphotopsias, the positive and the negative dysphotopsias. And Jack Holliday, as you well know, is very passionate. So is Sam Mascott, who was involved in the task force in sorting out these various forms of dysphotopsias. So in the field test survey, there were 86 questions. Eventually, we'll hone this down so it's more manageable. But there were over 700 patients that filled out the questionnaire preoperatively. We noted the frequency, severity, and bother at the last 7 days for 14 different symptoms. This included glare, hazy vision, blurry vision, starburst, halos, snowballs, floaters, double images, rings, distortion, light flashes with eyes closed or open, shimmering images, and dark shadows. And I have to again thank Gun-Young and his team for being able to simulate this with images as well. And we also asked when the symptoms occurred, whether it was with wearing your glasses or contact lenses or not wearing them, or with and without them, as well as the time of day. So this is our reference image. It was developed by Gun-Young's lab. And you'll notice this is actually the University of Rochester campus, if you've ever been on our campus. And this particular image is simulating dust conditions. You can notice that you can almost see the license plate in the designation on the back of the bus, as well as the license plate here. That becomes important. So this is just a sample of one of the pages of the questionnaire, which deals with halos. This is the image that the patient would see on the questionnaire, and then it asks defined halos are bright circles or ridges that appear around sources of light, such as oncoming car headlights. Then asks, in the last 7 days, how often did you see the halos? Never, sometimes, usually, or always, in question 14. Question 15, when did you see the halos in the last 7 days, with or without your glasses or contact lenses? We also asked what time of day, during the dawn or dusk, or at night, and then how severe were they in question 17, and how bothered were you by the halos over the last 7 days, and not at all too extremely. So this is our baseline preoperative data that I'm going to present to you now on the 717 patients that did their preoperative survey. We asked about vision, and most patients reported either poor or only fair vision. 84% were in that category. 36% reported poor, 48% reported fair. In terms of satisfaction, it almost directly paralleled that. 83% were either very dissatisfied or somewhat dissatisfied. 48% were completely dissatisfied with their vision from their cataracts, and 35% were somewhat dissatisfied. Now, there were two prominent preoperative symptomatic groups, and I call these the blurry vision group, which included blurred vision or hazy vision, and the glare group, which included starburst, streaking, and halos. Blurry vision group usually occurred in about 67% of the patients surveyed. The glare group, however, was even more common. It occurred in about 83%, and it's interesting how this actually, it's kind of fascinating how they interpreted this subjectively. This is the blurred vision group, and I want to go back and mention that based on our surveys initially with the patients, they actually articulated the wording for this. So The blurred vision group described this image as blurred vision, but you'll also note that the high spatial frequency contrast was lost. If you look for that license plate again or the details on the back of the bus, it's pretty much gone. That's in contrast actually to what the patients described as the hazy vision or foggy vision. Here, the high spatial frequency was actually maintained. You can almost see the license plate. You can almost see the detail on the back of the bus. If we go back to the blurred vision group, you can see there's not enough detail for high spatial frequency, whereas with foggy vision or hazy vision, there was some. So this blurred vision group, in this group, the symptoms were most prominently associated with dissatisfaction in worse vision. It was most noticeable with daytime conditions, and that's really important compared to nighttime. And you'll see that compared to the glare group in just a second. Pre-op overall, 67% of patients noted blurred vision or hazy vision. And post-op, this decreased to 22% of the patients surveyed at 6 months. Now, as I mentioned, we don't have full 6-month data, but we have enough that we can tell pretty well that there was a pretty significant drop in blurred vision. There was a 45% decrease in symptoms based on our preliminary 6-month data. But it's also interesting that 22% of the patients still had some blurred vision. And you need to understand that we haven't sorted out the monofocal group versus the multifocal groups at this point, nor have we sorted out the issue of whether they had some residual refractive error. So all that needs to be sorted out, the 6-month data, and we hope to give that to you later at some point. In terms of the glare group, you'll notice that these are the images that were developed. We had a snowball image, a halo image, a starburst image on the lower left, and streaks image on the lower right. This was all developed again by Gun Young's lab here at the University of Rochester. And the glare group was by far and away the most dominant symptom, and it included starbursts, snowballs, and halos. And again, these were in the patient's own words, and over 500 patients of the 700 plus patients studied preoperatively noted it. The interesting thing was it was really pretty low frequency of symptoms during daytime condition, less than 10%. I thought that was kind of very, very impressive. At night, though, it's like a vampire. These images dramatically increase. They go up to about 77% of the patients noting it preoperatively for starbursts, snowballs, and halos. And they dominated all other symptoms by far at night. The change from pre-op to post-op, and again, this is the preliminary 6-month data, but 83% noted at pre-op, but only 36% noted at post-op. And even when they noted it, there was a fairly significant reduction in the severity of the symptoms. Overall, 47% decrease in the frequency of symptoms in our preliminary post-op data. So again, we see the glare group just to remind you of snowballs, halos, starburst, and the streaks. So a couple other things just to finish up. Pre-op floaters were very common, and we were glad that we included this because I think it's going to confound some of the information otherwise. It was noted as the next most common symptom, 49% at baseline pre-op. The symptoms were actually reduced at night. Only 23% of patients noted it was problematic at night. And the severity of floaters was far less than the glare or blurred vision group. So they were less bothersome to patients overall in that pre-op data. The other subjective complaint that patients noted was double or multiple images. As you can see in this car image, the car light is kind of smeared and doubled. Here, the bus light is actually doubled as well. And this was actually moderately frequent, 27%. But the important thing about this, that when it occurred, it was usually very, very disabling and problematic for the patients. So in summary, we're reviewing FDA clinical trial, the Academy FDA clinical trial, basically we found that in the 717 patients that there were two major groups. The blurry vision group dominated symptoms during the daytime. In the glare group, which included starbursts, snowballs, and halos, dominated at night. The postoperative follow-up data will report on hopefully in a few months, and it will make it possible to kind of sort out this massive amount of data that we have. So stay tuned for more information as we get it. Thank you.
Great, thank you, Scott. I'm assuming that hopefully by the Academy meeting of this year that these results will be kind of tied together and we'll get the full presentation on the post-op.
Yeah, we're hoping to get that. I'm hoping that we get it sometime later in the summer. So
great,
massive amount of data. It's a lot to sort through.
Sure, absolutely. But looking forward to it because I think it's highly valuable to have this type of information because it really provides you feedback on how to improve designs and try to mitigate some of the issues that people face in the real world.
Yeah, it's really tough for clinicians to kind of sort out the subjective symptoms, and it goes right back to what Damien and Ron were kind of talking about. We've got the Wild West right now, and this kind of brings the sheriff into town and sort of gives us some continuity where we're not trying to sort out apples, oranges, and bananas.
Okay, let's see. So it looks like George Gao has left, so we'll unfortunately have to miss his question. Ron, did you have some comments that you want to?
Yeah, I think I want to make up to everybody. I'd like to make a quick comment, and I think Damien kind of alluded to it with all the new EDOF lenses are, and then of course Scott, you kind of drill down into how do we begin to characterize this. It's very complex for surgeons to know how to navigate the selection process of people to get the right kind of IOL because of all these different symptoms and everybody has different impressions of what that effect is, and even different thresholds for what they think is acceptable for their patients. Add to that the fact that the cost structure of this is also very fluid. We now have EDOF lenses that are priced almost at the same as a monofocal lens and give a little extra depth of focus. So how do you sell somebody a potentially cheaper modified monofocal versus a more substantial EDOF lens and the different pricings that are going on? The complexity of it is almost out of control, with what a surgeon wants to navigate. And I think we almost have to drill down and have very, very kind of concrete things so that there's not a lot of false advertising going out, with what something can deliver.
Yeah, the other thing about this is that when you look at the relationship between the clinicians and those companies and the patients have almost no say in this up until now. And this actually creates a language or a communication system that allows the patients to actually articulate what they're experiencing in a more objective and validated way. So I'm optimistic that this is really going to provide a really nice tool for clinicians to make more objective and more reasonable decisions in terms of all these different pros and cons that you, Ron, and Damien have talked about.
Yes, in my experience, I would say after those years in this field as both a researcher and a clinician, that the bottom line is, in my practice, it's going to be a bit deceptive for most of the companies, but when a patient has a severe cataract and is motivated to see well at more than one distance, you can try any lens. If the lens provides the patient with spectacle independence at the level he expected, it's going to be fine. When he had a severe cataract before, the thin ice is the typically -2 clear lens 45-year-old patient for who, regardless of the quality of the IOL you are considering, you will probably induce a deception, because the patient will tell you, with my contacts it was better at distance and without it was better at near. than that lens. And I could really publish all these observations that I have, which have one thing in common when patient comes to you for a second opinion after deception and visual problems with multifocal or EDOF or whatever, is that they didn't have any cataract-related visual symptoms before the surgery. And again, I tell my resident when I teach them that when you see those lenses with opacities, scatter, anything, any diffractive, refractive, whatever you call it, will work fine. If the patient tells you, I have a cataract, but I'm not so bad these days, and the vision is 20/30, and you have an OCAS or HD analyzer, which is very, very high. And that's really clinical evidence. It's simple, but I think that's something we should not lose sight of.
Yeah, I like Susanna Marcos's Symvis because it, can show patients pre-op what they might experience if they have a multifocal IOL. I also think, developing some images and showing the patients before the actual procedure so that they know you and they have actually talked about it before, because when, I see the same thing. I have many patients referred to me that are unhappy because they got a lens that they didn't anticipate having glare and halos. It's much better if the patient had that disclosure beforehand, because they're not nearly as angry and disillusioned.
I was going to comment, the images you have from Rochester kind of showing what halos, what snowballs, what glare looks like. I think that's something that really needs to be promoted, and people need to know what it is, because it's very elusive when you talk about halos and glare, and patients don't know what it means. And even a lot of surgeons don't know what really characterizes as what. It's nice to kind of drill that down from an educational perspective.
Yeah, and the really interesting thing is we don't have a common language either. Now with these images, the doctor can say, well, this is starburst, or this is streaking, and this is blurry vision, or this is foggy vision. Now we start having our own language that we can use, and otherwise every clinician is going to use kind of a different term for what they're trying to explain to patients. So it's almost like we're developing a better communication system for the patients, the manufacturers, and the clinicians.
Okay, I think we have a few questions from the Q&A session. So I think the first one's directed towards Scott. So why doesn't the halo simulation show what I see with my Panoptics, 3, 4, or more concentric rings?
We do have, actually, I couldn't show you all the different images that we've generated. I think there are 18 that Gunyang and his group did. Gunyang painfully did this for us. But because we went back and forth many times on this, but we do have one that has sort of a spider web appearance that demonstrates that. We also, I didn't have time to basically show the demonstration of a negative dysphotopsia, but we spent a lot of time on that one, and also positive dysphotopsias with daylight and positive dysphotopsias with nighttime vision. So maybe next time around we can show you those.
Yeah, and I think the key is to stay tuned for the report, because I think they'll all be in there as well. Kind of along that lines, Young So asks, where can I find the final published report when it's ready?
We haven't done that yet. We don't. We're just in the process of continuing to aggregate the data, but it would be in ophthalmology. My hunch is there'll be several publications because it's a massive amount of data.
Okay, and so do you expect it to be sort of open access to the community, and so that people who may not have access to some of the journal articles can still readily get this information.
Yeah, I agree with that concept. We do want to get that out to everyone that we can. So we'll work with the academy. I think the industry people want to get this out as well. So it's disseminated widely, so we can start developing a common language with our patients and clinicians.
Great. Let's see, from Anonymous. Do you interpret these pre-op symptom percentages as a survey of total lens replacement patient symptoms or symptoms that most often drive patients to premium IOLs?
I'm not sure I understand the question.
Yeah, so I think the question is that you saw high pre-op symptoms. Do these people tend to go for premium IOLs, or do they tend just to go for correction?
Well, we haven't actually analyzed that, separated that out. And we also made sure that there were monofocal patients included in the study. And the purpose of the study was not to sort of isolate one lens as being better or worse than another. The purpose of the study was to develop a questionnaire that was validated, that would articulate, some of the symptoms that the patients have had, both preoperatively and postoperatively, and try to start sorting out, what the characteristics are of a patient's complaints and dysphotopsias.
Okay, and then I think our last question here from Daniel Calero. Thank you for your presentation, Scott. What is the origin of the double vision in the test? Is it permanent or does it disappear with time?
You mean the questionnaire is just simulating the double vision.
Mm-hmm. Do you have any insights into potential causes for the double vision?
I could speculate. Ron, do you have any thoughts about double vision with cataracts? I mean, it'd probably be an interesting thing. Gunyang?
Yeah, I could add some potential the answers for that questions. I think astigmatism could be one of the major sources to create the double vision. Astigmatism could be induced by the decentration of aspheric intraocular lenses, or you could have astigmatism on your cornea. So when you have uncorrected astigmatism, and one of the double vision is one of the common visual symptoms.
Yeah, I know Charlie Campbell a number of years ago showed that if you combine coma and astigmatism, you can get two very clear but displaced images. So.
Yeah, I was going to say,
I would agree. I think coma or decentration is probably one of the biggest sources for double vision.
Well, if a cataract gives you coma or let's say secondary astigmatism, my hunch is that probably would do something as well. But Jim and Gunyang probably know that better than I do.
Sometimes you can have patients complaining about triplopia. This is observed in a nuclear cataract patient, and probably due to the increased refractive change along the lens sutures. That's my explanation. But I have really patients, a few of them, they say have triple vision, pre-op. And it's straightforward, the Wavefront, of course.
We got to get the three images to go this way instead of this way.
That's a good idea.
All right. Well, thank you, everybody. I think we'll wrap up the session there because we're running a little over time, and I know Ron and Damien need to run here. So thank you all, and I encourage you to participate in the future webinars. And we have the dates here up on the screen. So please, sign up for these and participate, because I think a lot of exciting information here, and we just have to make the best of our current situation. And hopefully next year we'll all get together face to face to communicate the new findings from that come up. So thank you, everyone.
Thank you.
Thank you.
Thank you.
Thank you, everybody.